It is a great honour for me to introduce Professor Rafferty, who is Professor of Nursing Policy at King's College London, President of the Royal College of Nursing, and importantly for this evening, an alumni of Green Templeton College, where she studied modern history and became the first nurse to obtain a DPhil from the University of Oxford. Professor Rafferty has worked clinically in Edinburgh, Nottingham, as well as Oxford, combining and innovating both clinical and academic roles. She holds fellowships from the Royal College of Nursing and the American Academy of Nursing, and was elected a Fellow of the Academy of Medical Sciences in 2019 and the National Academy of Medicine and Science in the United States in 2020. She served on the Prime Minister's Commission on the Future of Nursing and Midwifery in 2009 and was a member of the Parliamentary Review of Health and Social Care in Wales, which reported in 2018. She was appointed a Dame in 2020 for services to nursing. Professor Rafferty continues to be both a historian and a health workforce and policy researcher, and I'm looking forward very much to hearing her thoughts this evening on the future of nursing. She's agreed to take questions at the end, as I've already said, so please remember to raise your hand and send a message on chat when you want to ask one. Enough from me. Professor Rafferty, over to you.
Well, thank you so much, Paul. It's a real honour to be here this evening. And I really want to take advantage of this occasion to actually pay tribute to Green Templeton College and indeed my thesis supervisor, Dr. Charles Webster from All Souls College. My moral tutor, Sir Muir Gray, who was also a steadfast support throughout my DPhil time here, but also subsequently too, very much like Charles. I'd also like to honour the support that I received from colleagues at the Wellcome Unit for the History of Medicine. I know that one of my long-term pals and friends is here, Liz Perrott, so I'm absolutely delighted to recognise the debt of gratitude that I also owe to the unit, and indeed the conversations that your previous warden, Denise Leasley, and I had both at King's and indeed when Denise was at Green Templeton about Florence Nightingale. So it's great to be able to really provide that roll call of tributes to some of my closest supports and friends. I'm now going to share some slides and hoping this works. And if we can go here. There we are. Hopefully you can see that. I'm sure Paul will tell me if you can't. So here's an updated vision of Nightingale, a kind of Andy Warhol version for the 21st century. So I'm going to talk a bit about Florence Nightingale, but use her as a kind of reference point to make several other comments and thread an argument around where nursing has been, where it's at, and where it might go in the future. Now I'm trying to advance my slides. That's not happening. There we are. Brilliant. So first of all, I'd like to kick off by considering Nightingale's legacy and what relevance that she still holds for nursing today. Then consider and explore some elements I think we need to build on after this ghastly pandemic to support nursing's contribution to global health security. Nightingale was a global figure, and I think her legacy is as relevant at that level as it is at our national level. And then have a stab at outlining a vision of interventions that, this is more of a personal view, that I see are important to really set the nursing workforce on a sustainable footing after the pandemic and position us positively for the future. And this is built on really some of the lessons that I've also learned during my period as president of the Royal College of Nursing. So without any further ado, this is probably the most familiar vision and version of the image of Nightingale as the lady with the lamp, so beloved and celebrated by the Longfellow poem. It's a somewhat sentimentalized vision, and it's probably the most potent one in the public imagination. But I think it's important to remember that Nightingale was much more than that. And she was polymathic in her talents and indeed in her interests. And she was incredibly well networked through family connections and her flat in London, and also 2 major houses, one in Derbyshire and one in Hampshire, the drawing and the dining rooms of which were peopled by some of these politicians and scientists and literary characters. So she was incredibly well connected, not just with royalty at the time, Queen Victoria and Prince Albert, but the Charles Darwins, Lord Palmerstons, of course, and Sidney Herbert, who was her champion and great support throughout well, his relatively short life. But without his, I think, patronage, would never have ended up in the Crimea, Mrs. Gaskell and others. So her sort of links to the scientific and the intellectual aristocracy was where I think she drew a lot of her influence, and she knew how to network exquisitely well and land, to use that modern day term, land her sort of policy points and sometimes punches. But she was not just a nurse, I mean, in the sense that, I don't mean just a nurse, I mean, she was much more than fulfilling her ambition to be a nurse and actually provide nursing care. Of course, she was an innovator in public health, a leading sanitarian at the time. And indeed, she, as we shall see, was instrumental in supporting the building of hospitals, comparative social science, epidemiology, and had significant theological and literary interests, as well as talents, actually. And I think that's part of the key to her success. Was she was a first-class communicator. And I think nowhere is this illustrated more vividly than in her leading edge design of this infographic, which there's the coxcomb or the Rhodes diagram, which she developed herself. I think she really was a great believer in evidence itself not being self-evident, that it needed a narrative, and what better way to condense a narrative than to provide it in pictorial form. And this slide here demonstrates that very graphically and economically, that soldiers in the Crimea were actually dying more from their the consequences of their battle wounds rather than battle wounds themselves, and the want of good care, in summary. And so she was really one of the great kind of data scientists of her age, and of course was well linked with William Farr and others who held the golden keys to the data through the census. And in that sense, she anticipated, I think, the kind of substrate that we rely on in health services research, linking data systems together. If anything, she was obviously known as an angel, but she was more of an administering angel, I think, very clued into and tuned into leadership of health systems. And she used that data to huge advantage in her publications, not just on civilian health, but on the military, of course, par excellence, not just in this country, but also in India. And she was inspired in developing her quantitative skills. I mean, she was mathematically gifted, in fact, had extra teaching from from tutors which her father had retained. And then she was mainly educated, by her father, but she also spoke several languages. And in fact, she read, the blue books, the kind of epidemiology books on hospitals. And every time she went abroad with the family on holiday, she would scuttle off on a little assignment of her own to do some personal research on the local health facilities. And that intelligence gathering was absolutely critical in finding sources that she could later draw into some of her most famous epidemiological writings, such as notes on hospitals. But Adolf Ketele was an interesting character. He was a Belgian statistician and sociologist. I guess before the term sociologist was actually invented. And he was fascinated by this idea of the mean and normal, what's what we'd call normal distribution. And Nightingale shared this fascination. And he wrote a book called L'Homme Moyen, the average man. And he was very interested in how, deviation from the norm could occur. And that particular book was about, criminological behavior. And given the Victorian fascination with criminality, it was trying to explain, these extremes of kind of positions of virtue and vice, if you like, and its distribution in the population. So she was greatly indebted to him, and they wrote back and forth. And he was equally an admirer of her work. And I think there's a copy of her book, her own personal copy of L'Homme Moyen in the British Library with little annotations. So if you're interested. So that kind of turn towards quantifying social phenomena, social physics, as they were coined by Ketele. And, along with Ketele, his contemporary was Auguste Comte. You've got the development of positivism at this time, and the development of definitive knowledge, this quest for clarity and certainty. So it's part of that sort of desire to quantify observations more generally. And she was very much on trend and in tune with that. But her most famous book, which became a bestseller and a real blockbuster, was published in 1859, Notes on Nursing, is written in a very different style and is appealing to a very different audience, because this was very much appealing to the female heads of households and full of, fantastically fascinating information on how to look after the general population in the home, and lots of little hints and tips about how to keep fresh air flowing in the so-called sick room, tempting the invalid with little dishes, little tapas, I suppose, the use of color, the use of light, flowers to brighten up and cheer. I mean, it's really a kind of compendium of comfort measures, all underpinned with what we would then, I guess, has subsequently come to be recognized as having a scientific core and basis. But just thinking of COVID for a moment, I mean, that's exactly what you need when we're in the grip of a pandemic, where actually most people are self-isolating at home, and often, you don't have, if you're living on your own, you're really having to fend for yourself. So I think there's definitely a need for Notes on Nursing to be updated, and someone might write the next bestseller in that genre. But it's also a masterclass in kind of rhetoric and how to persuade the reader towards behavior. So it's somewhat anticipating, might be a little point stretching too far, behavioral economics and nudge theory too, but it's just beautifully written, stylistic. So she was a great stylist as well as a producer of, really titanic substance in her writing. And of course, having said she designed data systems and ways of actually presenting and communicating data, she was also very interested in the design of hospital buildings and architecture. And St. Thomas's was one such building, though she didn't approve of where St. Thomas's was actually being built on the Thames, which she saw as a sewer and too close to the miasmatic vapors that would cause infection. But nevertheless, she was so attentive to detail in infection control. I mean, the whole environment had to be designed around infection prevention and control. And of course, that's something that she recognized and drew many lessons from her experience of the Crimea. And remember that Scutari barracks itself was actually built on a sewer. So, and she had investigated the high mortality there and tracked it back to that particular cause. But it wasn't just, the physical environment, it's also the psychological environment that she wrote about. And in fact, that's something that we're very conscious of today in terms of the research that we do on workforce, what motivates people. And I think her kind of panoramic view of the healthcare environment was something really that anticipated much of the theory that we still rely on about creating a positive practice environment in nursing today. And she was very much of the opinion that nurses and women needed to be in charge, and certainly from a governance point of view, that's something that the Royal College of Nursing is firm in its belief that nurses need to be engaged in decision making and governance, have skin in the game, if you like, in order to be able to exercise their expertise and actually improve outcomes tangibly for patients. But her writings and work on hygiene remain highly relevant. And of course, we had to fall back on many of those practices, and we still are. Social distancing, ventilation, and all the caution around aerosol generating procedures owes a lot to Nightingale's theorising and ideas. And although a lot's made of the fact that she didn't advocate germ theory when it was first promulgated, I think there's this rather black and white view that you're either a contagionist or you believe in germ theory. And of course, these two systems can operate in tandem and coexist simultaneously. And eventually Nightingale did agree and condone and accept germ theory. It did take a little while, but I think many practitioners, it wasn't a sort of automatic acceptance of germ theory for many. And you could have variations in practices in the same hospitals. I mean, Lister's, when he's working at King's, had many of his colleagues who didn't adopt, antisepsis, and that's well known in terms of innovation and its dissemination. So I think her teachings have great relevance, and of course the field hospitals during the pandemic bear her name, and she was a great advocate. She also helped to design field hospitals, and even to the degree of, and this is something that comes forth in Notes on Hospital, being meticulous in her analysis of the cubic distance between beds that was necessary to prevent infection. And she was so attentive to detail that she, and in its relationship with infection, that she would also theorize on whether and speculate on whether the materiality of a mattress, whether it's made of horsehair or indeed hay itself, which of these materials was more repellent to infection. and the plaster on the walls, would it be more absorbent of carbonic acid, which was the fumes, the noxious fumes that was given off by miasma, and it was thought to be the cause of transmission of disease. So she had this extraordinary ability to view macro systems, this helicopter view of systems, and then to kind of, dive down into this detail. I mean, it's quite extraordinary having that intellectual range and grasp. And it's I think it's useful to kind of speculate, what would Nightingale say today if she were here confronted with coronavirus? Well, there's no doubt in my mind that she would be bossing Boris, right? I mean, she would be hammering on the door of number 10 and saying, come on, Boris, get off your bike, actually, because put me in charge of logistics and I'll sort out the supply chain of PPE, which of course procurement was one of the big achievements that she accomplished in the Crimea, and having a work around the very resistant military bureaucracy. So she would have been in her element, her infection control practices, and managing care in the community itself. I think she would have been such a huge asset, taking the lead in government policy. And I think it's really interesting as well to think about, where in the world of healthcare we were going, and we still are, pre and post-pandemic, because healthcare is a growth business, and it's actually, one of the major areas. The US Bureau of Labor Statistics was predicting that, care, computers, and clean energy are the three major growth spurts in the economy. That I don't think the pandemic is actually going to change that, though it may actually up the quotient on care. So that's where we need to be focusing on growing our workforce. And of course, I would say this, wouldn't I, as president of the Royal College of Nursing, but also a great advocate for our profession. But actually, nursing is at the heart of all of those areas because of the digitization of care, the development of new ways of delivering care remotely, often by nurses as well, through wearables and other types of devices, and clean energy. And if I just be allowed a little indulgence, I mean, this is a book that we've just published on the history of infection prevention and control in hospitals. And the front cover there actually is a photograph by one of my favorite photographers, Lee Miller. And you can see, I don't know if you can see these gloves there. This is from a American army nurse in the 1940s, and with re-sterilizing gloves. Now, this country disposes of something in the region of 4 billion gloves, disposable latex gloves a year. So maybe we need a little bit of history to help us deal with this clean energy and the sustainability issue, but that's for another time. But there's no doubt that, COVID has actually changed the way that we actually practice. I mean, as I've just mentioned, in terms of, remote monitoring and, telehealth care. But it's also changed I hope, the perception of nursing as a profession itself, and the way that we've also had to work and organize the way that we actually operate. I hope that COVID has smashed some of the stereotypes of nursing, and I think it's improved the public understanding of what nursing is actually about. I mean, of course, the focus has been, fulcrum of that's been on critical care and intensive care. But, I think nursing in the community, we can see the media have played a huge role in this by shining the spotlight on nursing, both in print media and in broadcast media, as never before. And nurses producing their own writing. I'm thinking of, this is pre-pandemic though, Christy Watson, whose book, The Language of Kindness, is now actually being represented as a play by Complicity Theatre Company. It's now in London, actually. It was in Warwick, and it's been Tunbridge Wells for the next week. So, and it's mesmerising, and I think gives, the arts can give unique insights into the work that nurses actually do. And I think we're getting away, I hope we're getting away from this rather sentimentalized kind of view of nurses as, you know, sentimental beings, if you like. They are full of emotions, and there's very little attention given to the cognitive complexity that nurses have to deal with. And there's no doubt that that really requires significant attention if we're going to close the gap that we have. The world's short of 6 million nursing. The last 6 million nurses out of 19 million that we currently have globally. There's a global shortage of nurses. I'm sure many of you are aware of this. And this report that was produced by WHO, the first of its kind, 2020, which was also the bicentenary of the birth of Florence Nightingale, is the first time that, would you believe, it's taken 2020 to bring all the data sets together of 193 nations and analyze, you know, where the strengths and the kind of weaknesses are within the nursing workforce. So I'm sure Nightingale would condone and wholeheartedly approve, but doubtless she might have a few words to say about, well, it's taken you quite a while to get there, hasn't it? We better get the foot on the gas. But I think just looking at the shifting demographics as well as the trends of where nursing work is actually heading, you can see that many people are having many more things wrong with them. So the rising tide of multimorbidities, which of course is going to be even more complicated with COVID itself, and COVID being a huge kind of exacerbator of these multimorbid conditions. The high volume, high intensity care, I think, you know, the reliance on the hospital, that's been looked at for, I mean, historians amongst you will say, well, here we go round the mulberry bush again. How long have we been saying we have to take care out of the hospital into the community? But we are going to have to make that shift, and we're going to have to really pace it up. But healthcare now is so demanding in terms of its intensity, its complexity, and the volume. And nurses are bearing the brunt of this. And we know from COVID, of course, that nurses, and we're doing research into this area, there's, 25 to 30% of the workforce that we've surveyed are saying that they're depressed, they're distressed, and there's 10% are reporting symptoms of PTSD. That's a long tail of a legacy that's going to move into the future. So even those nurses that we still actually have in the workforce are going to suffer. And third from an RCN survey in April actually said that they're intending to leave, once the pandemic is over. So we're in really a bit of a pickle, being the technical term in this country. We're under huge pressure. And those demands, changing the image of nursing, changing the narrative so that we are able to represent in a graphic way, as Nightingale did, innovating how we do that, that the cognitive kind of complexity of nursing care and decision making that nurses have to make, and they've got to make them super fast, smart care, needs smart nurses. These are all the things that nurses are doing. They're informing, they're designing new models of care, and being at the policy table, managing devices, and they're often doing this in a kind of hurly-burly of healthcare, working in partnership with others, being team leaders, being team workers themselves. And systems analysts, managing the hospital at night. Matt Hancock recently said, this was before the pandemic, probably before he was stepping foot in hospitals as such, but he was so impressed because all he saw were nurses at night. Yet nurses run hospitals at night, manage patient flow, all of these operations are nurse-led. So I'm hoping that one of the good things to come out of the pandemic is that we start to really challenge the received wisdom and the conventions that have actually held nursing back for many, many years. And moving into the nerdy bit of the talk, I'm sure Nightingale would applaud the increasing use of digital. Digital could be part of the solution to the nursing shortage, but of course we have to use it with caution, because it's not, going to be an automatic saver of nursing labour. I mean, it might create other unintended consequences, but nurses are undoubtedly delivering, sophisticated systems of care to patients, monitoring them, dealing with relatives, all the communication that comes with inventing systems during the pandemic to actually enable relatives and loved ones to communicate with their loved ones, sometimes in their last moments of their lives. I mean, it's so moving to hear people talk about that. A lot of that work is actually being done by nurses. So improving the digital literacy in the curriculum of nurses is really important. And there is a system of community-based nursing that I think we can feel inspired by. It's called buurtzorg, and it's neighbourhood nursing invented in the Netherlands, but now being centrifuged out to other countries. This is the inventor of it, actually, Jos de Blok, who's also a nurse. I had the pleasure of meeting him, and an economist. And, it's digitally enabled, it's coach enabled. These nurses are coached in their team working and developing new ways of optimizing the care that they can deliver to patients in their homes. And I think increasingly that digitally enabled community care is something that we really need to be capitalizing on for the future. And if Nightingale, were here, she would be relishing the development of data systems, of artificial intelligence, of machine learning, of systems where you actually get nursing data out on a report card in real time, instead of all these intricate systems that don't really talk to each other. You don't get data in real time, and you're scrabbling around to actually make sense of the data that we actually do have. So we've got some way to go in that regard, but I'm delighted that the chief nurse has been investing in appointing a chief nurse of digital, is working very closely with NHSX, but of course that needs to also be in care homes and in the community as well. So, and the digital natives who are our students, I mean, they're just going to love this, and I think that's what they're going to expect, to have a curriculum enriched by these skills. But I think nurses also need to be designing the system from the get-go, not just seen as a vehicle for actually delivering these. And research, I've had the privilege of being involved in, has also demonstrated the need to have sufficient capacity in nurses. We've demonstrated, not just in the UK, but across Europe, that consistently too few nurses means that patients are dying unnecessarily. And that's not only the actual numbers of nurses, it's how they're prepared and how they're educated. And better educated nurses to degree level have better outcomes for patients. And we believe that's something to do with the types of decisions, the critical thinking that goes into nursing, and having the confidence and the authority to also act on those decisions. So we reckon that actually, if you started to change your workforce planning mode, at the moment, we only plan on the basis of numbers of nurses. We don't even really look at skill mix adequately. If you were to change the parameters on that and have 60% bachelor educated nurses with a workload of 1 to 6 in acute surgical or medical ward, you could save 3,500 lives across Europe, we reckoned, in a year. And again, I think it just makes that point about nurses. And this again comes up in WHO's recent report and resolution at the World Health Assembly. The nurse is an essential underpinning for building resilience in health systems. And we demonstrated that in the book that we published through the WHO and European Observatory. But let me just flag up, and wave the flag for advanced practice nursing. It's one of the great hopes that I certainly also have, as well as better educated nurses. And I'll tell you, in government, there are people who are skeptical of this, and there may be even people who are skeptical in this audience. So I look forward to talking with you about that. But we need to be really training and educating nurses to be able to optimize their practice. And we need really highly skilled nurses as leaders. We need to invest in leadership as well as education as never before, because these nurses, these advanced practitioners, have all manner of skills, as I mentioned before, to manage a chronic disease, which is a burgeoning epidemic within a pandemic. And as I say, that situation is going to get so much more complicated. It is in essence a kind of syndemic where you amplify the effect of one on the other. And this has not been happening. We have not been educating either enough nurses, not point one, point two, certainly not at the right level, and thirdly, not promoting them. And this was classically illustrated by a recent situation in Northern Ireland, which of course was in a state of political paralysis for 3 years. And it basically meant that nurses were not able to progress in their career because there was no investment in continuing professional, or as I prefer to call it, postgraduate education and training. And there was pay status for these people. Hence, 50 odd percent, 50,000, which actually, no, it's more than about 70% of the workforce are at the very bottom bandings. Only 10% are at the upper bandings. And that is way out of balance from the type of skill mix that we need to confront the problems of the future. And one of the highlights for me during my presidency was actually going over to Northern Ireland. Nurses in Northern Ireland went on strike because they were fearful for patient safety, as well as very poor staffing numbers. And they just saw kind of race to the bottom, thought, we have got to do something. If we don't do it, who's going to do it? And it was just, so inspiring to see nurses there, so super articulate. They had the data at their fingertips, public on side. And indeed, a lot of the managers in the hospitals, although some of them were very tentative, patients were on side. Patients were saying, you've got to do this, and stiffening the sinews of their motivation and their confidence. I mean, we've got, enough is enough, and you have to take a stand. And I thought that was a brilliant stand for nurses to take in Northern Ireland. And there's, progress been made since that point. The World Health Assembly, as I mentioned, just reported last week, and there's a long resolution on the future of nursing midwifery, which links to some of the final points that I want to make around, workforce planning. But I mean, again, it's sending out a kind of message to global health leaders, health ministers, and essentially governments that you've got to get your act together and invest in this. And this is, a kind of personal view, really. Pay is important. These are my 5, points for a sustainable workforce and recovery. Pay is important, and we have a big pay campaign at the Royal College of Nursing. 12.5% we're asking for, which actually is necessary, only takes us back to the value of nurse pay 10 years ago. So it sounds a lot, but actually, because we've experienced such a decline and depression in nurse salaries and the values of nurse salaries, it's just taking us up to a historic point of the past. But to my system, in my view, it's not just the starting point of pay, it's actually the end point and the end game of pay, which is important. It's progression through the pay scales. As we saw with the Northern Ireland case, there's far too many nurses who are in the bottom ranks and certainly not enough progress up. And why is that important? Because we're not actually developing the leadership function that we need in order to strengthen the support that will create the sustainability and the motivation for colleagues coming through the ranks. So it's not just pay itself or the starting point, it's the whole pay system. And I'm really puzzled as to why nurse pay has not actually been able to keep pace with the demographics and the demand. The pay system clearly has not been working, or it's been used as a tool of implicit rationing. That's got to stop. We've got to fix this. It's not just pay. Having a pay increase will help, but it will not be a long-term solution. Workforce planning. Well, I'm sorry to say in England, I really don't think we've got any workforce planning. We've got a target of 50,000 nurses, a government target, top-down target to actually meet. There is no definition or specificity on what kind of nurses, where they should work, you know, their kind of distribution and the roles that they should assume. I'm sorry to say, a target of 50,000 nurses is not a planning strategy in my book. And we need to move from the short-termism that we've had of the past and to move to a long-term investment portfolio and strategy, to have planning based on demographics, population need over a 10-year period. I mean, it's not dissimilar. We don't treat doctors like this, as doctors in the audience, I hope. You know, honestly, if we treated doctors in this way, we wouldn't have any doctors in this country. And we've seen significant cuts to the actual supply of students, a boom-bust approach to funding, and even the investment in the bursary, which was taken away a few years ago, is replaced with, you know, 5,000 maintenance grant at the moment. And we have seen a COVID bonus and bounce in student numbers, but that's nowhere near enough to actually fill the shortfall and the gaps that we actually have. And what I'm saying is we need to be kind of moving up. We need to be enabling people to progress and actually building solidity into that work, into the workforce at senior leadership levels, because those are the people that we rely upon to support those coming behind. And it doesn't take, you know, let's face it, a structural engineer to tell you that if that is not done, we are heading for one almighty crash in our health system. And we can prevent it, and we must prevent that from happening. So the second point in my little solution is workforce planning and getting away from a system of a marketized system where we actually base our workforce planning on placement provision for students. That's totally inadequate and a broken system, and it will never work. Continuing professional development and I prefer to call it postgraduate training and education, again, has suffered the same kind of fate as undergraduate training. It's been kind of, these budgets have been raided at time of austerity, and certainly, again, a boom-bust kind of oscillation in investment and funding has been the order of the day. That's no way to plan a workforce. That doesn't lead to any predictability. Again, it's very off-putting for people. They don't know whether they're able to have any way of seeing a career in front of them. It destabilizes the whole career structure. Career structure is still far too wobbly. Simon Stevens is quite keen on saying that, you know, when the economy sneezes, the NHS catches a cold, and to which I would add, nursing catches pneumonia. So we've got to have a stable investment in CPD. I would like to see it on the same basis as doctors. Whilst nursing budgets were being raided and ravaged, doctors' numbers were expanding, and we can't allow that. Why? Not least, doctors create work for nurses. I mean, they're not going to have anyone. You guys are not going to have anyone to delegate to because we're not going to be there, and you just can't take that for granted. So leadership, again, we've got to invest in leadership as never before, and almost reverse engineer the way that we've workforce planned. Actually stop looking at students and start looking, what's the destination rather than the starting point? What types of nurses do we need based on epidemiological, population, demographic predictions? let's get some sense on this. I mean, you know, if anaesthetists and A&E doctors and GPs are planned on it's a bit of a guesstimate, and it always probably will be that informed by the available data. But at the moment, it's really woefully inadequate in nursing. We can't allow that. Sorry, I think, you know, we've not been ambitious enough, but we've definitely got to look at strengthening that leadership function. It's on a very, very shaky peg at the moment. And I'm just looking at my last little bit of the jigsaw puzzle because I need to minimize this thing so I can see it. Oh yes, safe staffing. How could I miss that? So we do have legislation in Wales and in Scotland, and there's mitherings, as we say in Scotland, around and plans to develop legislative reform for Northern Ireland. And indeed, potentially, at least this is our ask from the Royal College of Nursing, in the Health and Care Bill, for accountability to be enshrined with the Secretary of State, and for a demand-led modelling system to be carried out every 5 years. So that duty would be incumbent on the Secretary of State. So that would help to strengthen the structure. Ideally, we'd want to see legislation, and we're pushing for that within England as well. And we also have staffing standards, which I think is actually helpful as a kind of ready reckoner for nurses on the front line to be able to use as a kind of metric, a way to pass a kind of rod over of evaluation over their staffing situation, and a checklist for assurance supplemented by their own professional judgment as to whether the staffing standards are actually being met. So we've taken that stand from the Royal College of Nursing, and I think it's got the potential, hasn't been tried yet, to be very helpful to the front line. So there are my 5 kind of main points. And just in conclusion, therefore, I believe that the future is actually fixable. We've become so psychologically attuned to believe that we are helpless and that the whole workforce situation is hopeless. It is not. We can do something about it if we align these elements together and enable them to work in synergy with each other. I actually think we can make significant step changes and inroads to develop and provide a sustainable future for healthcare. But we need to really go up market, be much more ambitious, and rethink our whole workforce planning kind of model, and invest in highly skilled nursing at the top. The other point I should have made is about regulating advanced practice. We have advanced practitioners who cover a whole gamut. Again, these are the people, as I mentioned, who manage the ballooning chronic disease conditions that we have in this country. Without them, they're not going to be able to cope, quite frankly, with those just numbers, the scary numbers. And therefore, it's very interesting that the countries, we are an outlier in this country. I'm talking about the UK, compared to Canada, compared to the US, Australia, and a number of our European peers. None of those countries have the scale of the shortage that we have in this country. And I believe that is a really important intervention to be able to remedy this long-standing problem that has plagued our profession for far too long. Global investment to protect and build this resilience in our health systems globally. We've got WHO backing, and scale up the train for digital solutions, the Nurse and the Nightingales of the future, and get nurses involved as designers as well as deliverers of systems. And I think the last word should go to Florence. You know, unless we're making progress in our nursing every year, every month, every week, take my word for it, we are going back. And I'll tell you this, we are not going to go back. Thank you very much for listening.